Just to introduce myself, I'm Dr. Tremontano here at the Neurocognitive Institute. I'm the medical director, and we do a lot of brain imaging and what's called neuromodulation here in the clinics, but also in our research. So today we're going to, it's a continuing series. We've been talking about, functional brain mapping, and we'll explain what that is, and these non-invasive neuromodulation interventions. We'll talk, about those as well. And we're doing a little series with some of the research studies that we're doing in Alzheimer's disease. That's one area, autism, which is today's seminar. So we'll talk about its applicability in autistic disorders. And there's a few other, I think, seminars coming up in other conditions. So let's dive into it, and we'll go about 10-15-minute segments, pause, take some questions on the different topics, and then we'll have some questions and answers in the end around 10:45-ish. So you should be able to see on my screen. I'm going to just move this out of the way. So let's talk about what functional brain mapping is, there's different techniques in functional brain mapping. So what it essentially means is you first have to do some kind of functional assessment, and that's usually referring to cortical functioning. The cortex being, the most sophisticated part of our central nervous system, that's what houses all of our cognitive networks. So we think about cognition nowadays in terms of networks, like hubs and connections, and we have hundreds of networks. These are different networks that activate during different types of cognitive tasks. So one way to think about cortical network functioning is to break it down by the cognitive domains like attention, working memory, executive function, language, visual spatial abilities, even things like the ability to regulate impulses, regulate emotions. For example, those are cortical functions. They happen to be more in the orbital frontal cortex, but nevertheless, those are still cortical functions. So when we talk about a functional assessment, what that means is you're doing a neurological exam of the patient's functioning, which is typically more the sensory functions, right? Like visual field perceptions and tactile perceptions, and reflexes and motor coordination and balance. You're doing psychiatric examination, because psychiatric conditions like anxiety, depression, obsessive compulsive, these neuropsychiatric related disorders certainly can present with fairly prominent cortical findings.
I can hear him, but I'm not seeing anything.
Is anybody else having a problem seeing an image? What I have on the screen is just a connectivity map from one of the functional brain mapping images. The brain basically with a bunch of blue lines.
Yes, I can see that, Dr. Tremontano. Ma'am, you're using the phone line, so you don't have access to the screen. You'll have to get the link in order to view the entire presentation, because you're tapping in the dial-in details only.
Yeah, if someone can send you over a link, you'll be able to click on that link, and you'll be able to see this image, or maybe Christian can send that over to her.
Yes, I did send the link already, so she can just click on that, and it should open to a browser on her smartphone or her tablet or her computer.
Okay. But I can describe, just right now we're just talking about the functional. I'm not showing the actual exams on there, just kind of describing what a functional cortical assessment is. So I was just saying it does involve, of course, history taking and getting a picture of what the patient's complaints and deficits are and their neurological, psychiatric, medical history, doing neurological and psychiatric types of examinations. And functional assessment also involves a lot of cognitive testing. That's where you're testing attention and information processing, speed, and executive functions. And nowadays, a lot of these functional-based testing are computerized, but they still can be on paper and pencil types of assessment, but they tend to be more computerized these days. So it gives you right down to milliseconds differences in patients' performances, and you compare those data sets. So, for example, in cognitive testing, you can give 4, 5, 6, 7 hours of testing, and at the end of your testing of all these different cortical networks, you'll have scores, and you can compare those scores to normative or individuals who don't have any neurological, psychiatric, or medical conditions. And it's called a normative database reference. So based on things like age, education level, you can compare your patient's performance on a particular test, like sustained attention, to another normative database comparison group. Let's say if you have a let me disconnect that. So if you have a 9-year-old that you're working up, let's say you suspect that they may have an autistic spectrum-based disorder, and we're going to talk a little bit about that. All the data that you get from that evaluation, the neurological, psychiatric, the cognitive, it can be compared to other 9-year-olds who don't have any neuropsychiatric related conditions. So you can tell from the normative database pretty much what areas are impaired. So for example, in autism, the reason that these kinds of disorders are a little bit more what we call pervasive, I'll explain, means that there's more than just a few networks, cortical networks involved. So one very simplistic way to break up the neurodevelopmental disorders, like autism from a brain mapping perspective, is how many networks are involved. So for example, if you have, let's say, a 9-year-old patient that you're evaluating, and they tend to show on their functional assessment a few areas of impairment, let's say attention, that means their capacity to have a consistent, to maintain a consistent level of attention over time may not be normal, may not be in comparison to the normative data where it needs to be. So that would be an attention-related deficit. Different details of that, but just from an explanation point of view, that would be an abnormality in attention. And let's say they have some other abnormalities, what's called working memory. Working memory is like a buffer type of memory. It's very much related to attention. If you're, writing down a phone number that you have in your head, you're holding those numbers in your working memory for a few seconds until you can scratch them down onto paper or punch them into your phone. So that very kind of buffer-like memory we call working memory, that may be impaired, let's say in this example as well. And there's reasons for that. Attention, working memory share a lot of the same highways and byways in the cortex. And you may also have executive dysfunction. Executive is a big network, attached pretty much to many other networks in the cortex. And that's what allows us to execute a response. So once you pay attention to something, for example, you try to decide what is essential and what you're paying attention to. That's another network. But then you have to do something with that. You have to execute something, either respond or not respond, carry through your responses, switch your responses, right? So let's say if you do your evaluation and these three kind of domains or networks are the only areas of impairment, we tend to call that attention deficit disorder. If there's no other reason to explain that, there's no brain injury or any metabolic or infectious-based conditions going on, and it seems to be neurodevelopmental based, meaning it's been there as the child is developing, we tend to call it attention deficit disorder. That's the typical triad in that disorder, and generally involves those three networks for the most part. So the overall cognitive functioning is going to be fine typically, or in many cases better than fine, above average. But those three areas would be significantly impaired, and that's very consistent with, for example, ADHD. So you ultimately see if that diagnosis based on your clinical information is consistent, and then you could then go image that patient with now brain mapping, because you already did the functional piece. You kind of arrived at a diagnosis, you made some hypotheses about what's going on, and if you do functional brain imaging, and those are particularly the major networks that are impaired on imaging, and it's consistent with the findings that you would expect to see in that disorder, well, in that case, you're probably working with a patient who has attention deficit disorder, not autism, right? If the same patient also has, let's say, a learning disability, they may have, these same problems: attention, work and memory, executive. But in addition to that, you find that they don't process auditory information that well. And when you give them information verbally, like learning information from a story or learning information from a list, that they struggle acquiring that information and they struggle building upon that information. In other words, their learning curve is not as steep as it should be in comparison to the normative age group that you're comparing it to. So in that case, you have a verbal learning disability with your ADD, which is not uncommon, particularly in boys. So you're still not making a diagnosis of autism because works, attention, maybe work and memory, executive. In this case, maybe some left frontal parietal, left frontal temporal, some more networks in that left temporal lobe and its connections to the rest of the brain, for example. So in that case, that would be maybe an attention deficit with verbal learning disability. So maybe you have three major networks plus one. Now, when you're dealing with autistic spectrum disorders, you have typically that subset. You're going to have typically attention-based, work and memory-based, maybe executive-based, plus maybe some learning-based, plus other networks are going to be involved. Typically social pragmatic networks, networks that are engaged and activated when we're plugged into social situations or engaged in social situations or have to read social situations and behave accordingly based on the social information that we're taking in, or based on the expressions of someone else's affect and our ability to adjust our ability to behave one way or another based on what we're reading in somebody's facial expression, or based on the context of the situation, realizing that based on this context, I have to alter all those kinds of functions are typically impaired in autism, right? So that's how we do it in functional brain mapping. So if you have, kind of like three networks and it's attention, work, and memory, and executive, we tend to call that ADHD in the functional brain mapping world. If you have those networks and, some learning disability, dyslexia, for example, with ADD, we tend to call that ADD with learning disability, and learning disabilities will vary from patient to patient. But if you have all of that plus more, particularly if you're bringing in, some of the social networks, so we'll call the social pragmatic networks, with all those other features that we just talked about, now we have multiple networks involved that tends to be more pervasive. And if the other clinical criteria support the diagnosis, then you tend to make a diagnosis of autism, and you'll see multiple networks involved on tests called functional brain mapping. Now we're going to go into functional brain mapping and what autistic disorders look like on functional brain mapping, and then we'll get into a little bit about, can we do anything about that in changing those signatures on brain mapping that may be relevant to the patient's autistic disorders. But before I do that, we get into the kind of functional brain mapping piece of it. Any questions on neurodevelopmental diagnoses, such as what we touched upon, or the functional part of the evaluation? Okay. So up to this point, we really talked about more of the clinical side, in terms of, doing good clinical histories, doing good functional cortical assessments, which include the neurological and psychiatric workups and a lot of cognitive testing and so forth. And then ultimately you see, in comparison to a normative database where the patient is falling in this function or that function. And now you've built your hypotheses about what you expect to see. So if you have somebody who, has, let's say in this case, what you're seeing here on the screen is some pretty significant disconnections. The blue represents some disconnections in some of the parietal areas with the frontal areas. And this is connectivity abnormalities is what is so striking in autism. So when you look at the functional imaging of in autism, unless you're doing micro measurements, usually the structural is pretty okay. We tend not to see a lot of structural abnormalities on structural imaging, and even the localization maps in functional brain mapping, whether we use MRIs or EEGs, brain mapping is really software analysis. So it depends on what you're feeding the software. So if you're feeding it MRI data, that's called a functional MRI. If you're doing it at rest, or maybe you've got the patient in the scanner doing, particular activity like an attention-based or executive-based activity, or if you're feeding it EEG data, you're going to get a little bit of variation in terms of the different types of mappings based on what type of data. In this case, we're looking at what's called electrical neuroimaging, and what we fed the computer in this case is EEG data, electrical neuroimaging data. And then we've isolated kind of the frontal parietal network in this case because the patient has executive dysfunction on their functional assessment, right? So we were able to diagnose that one of the problems that this patient has is what's called a dysexecutive syndrome, meaning that their ability to, kind of initiate and change their strategies on what they're doing based on feedback that they're getting, and then from that change strategy, evaluate whether that change is good or not in order to bring their task to some kind of completion. Those types of abilities are really impaired in patients who have executive dysfunction, such as in autism. So right now we're working on a autistic protocol where we're trying to see, about, using these different diagnostic techniques to, diagnose the executive dysfunction, which is almost always present in an autistic disorder. And we're trying to say, okay, can we isolate that connectivity abnormality in the executive network, in particular the parietal and the frontal hubs, because those executive network is very, very large, but the frontal and parietal hubs play a really, really big role. So if you have somebody that has autism and has an executive dysfunction as part of their autism, right, we're going to see in the world of brain mapping and neuromodulation, can we do anything about that? Can we first see the connectivity abnormalities, because you need to see them, you need to identify them on some kind of imaging technique, so that you can then use that information almost as targets to try to hit or try to modulate when you have these abnormalities. Like in this case, you have a lot of what the blue lines are representing here, just a lot of disconnections. These are what we call functional disconnections. So when we measure the kind of activity at rest here and measure the activity at rest here and compare it to a normal, let's say a normal 9-year-old, this should be gray, right? This should be normal connectivity at rest between these different sections of this network. So when we see this is kind of some of the more prominent findings in the brain mapping literature with autism is really in the connectivity maps. So there's different ways to do that, like I said, with different equipment, different collection of data. But ultimately, when you look at the connectivity maps and all the different types of metrics that you can analyze in connectivity, that seems to be where a lot of the prominent problems are in terms of at least identifying these abnormalities in a diagnostic setting is on imaging, but within the connectivity suite, so to speak, within the connectivity tools that we can measure all these different components of connectivity. That seems to be what we look at when we're using imaging. And the exciting part about that is you can really change connectivity, quite dramatically with various neuromodulatory interventions, which I'm going to introduce that next. So like if you look at this baseline, abnormalities in connectivity, and I'll show you a follow-up in terms of the changes in connectivity, which is here. So in this case, after a few rounds of treatment, the brain's capacity went from, in terms of this frontal parietal network, went from relatively disconnected to some hyperconnectivity to try to get these parietal lobes, which we use to process a lot of our world, and then connect up to the front part of the brain to execute the appropriate responses based on the registration of this information, right? So you first have to register it correctly, or register it. Sometimes it has to be registered. In many cases in autism, it's not even being registered. And then you have to register it in an accurate way, and then you have to, beyond that, execute appropriate response. So it's a pretty hefty task for the brain. So what these two images are showing you is before treatment, you have relatively hypoconnectivity or disconnection, and then after treatment, you have these kind of massive hyperconnectivities that build up. Now, we're going to go into what we used to do this, and does this have relevance for the patient's disorder? Like, in other words, does their executive function improve? Just because you get, pretty massive changes in the cortex, in this case, in terms of connectivity, because that's the main thing that we were looking at, it doesn't necessarily mean you're going to get very significant changes in function. I mean, that's the goal, that's the hope, that we can help these patients, because usually their executive dysfunction is very disabling. But it doesn't mean that. Then you have to retest functionally to see how much functional improvement that you did get based on changing the cortex and the cortical connectivity in this way. Okay. So I'm going to again pause for some comments or questions here. Just, feel free if there's anything that you're not clear on or just want to go over. But so far we talked about the functional assessment. That gives us a hypothesis of what we expect to see in the brain. Then doing imaging, which is called functional brain mapping, whether at rest or during different activation tasks, using different types of equipment like MRI equipment, EEG equipment, and arriving at these kinds of images before treatment and of course after treatment or during treatment. So that's kind of what we've covered so far, just in a high level overview. So questions on some of the stuff that we've covered so far? Okay, so one of the questions was, let me go to that question. Open up this. So how long was the treatment and what did you analyze for the after results? So in this case, we've been collecting data for a while. So I'll tell you a little bit about how we've been doing it. And this is in support of a grant that we have applied for, and the grantor has asked for some additional data. So we've been collecting data. So I'll tell you a little bit about, what we're doing. So once a patient's been through the workup and a diagnosis has been made, hypotheses have been generated about what we expect to see, cortically, mapping has been done, hypotheses have been relatively confirmed. So once we have all of that, we're looking at these various forms of non-invasive neuromodulation. So let's talk a little bit about the treatment, and then we can get into your question, how long was that? So in the world of non-invasive neuromodulation, which is different from invasive. So invasive, like a typical example of an invasive neuromodulatory intervention would be like an implantable spinal cord neuromodulator, where you have patients with a lot of, let's say, spinal related pain from, let's say, a collapsed disc that's sitting on the nerve, and then you insert this little implanter to kind of break up the pathways that's coming up to the spinal cord to the brain. That would be an invasive procedure because it involves it involves that surgical procedure. Parkinson's disease, there's a technique called deep brain stimulation, where it again involves a surgical procedure, inserting particular equipment tied to a modulator to turn on and turn off certain structures in the brain to give the patients with Parkinson's disease some relief or attenuation of their deficit. So those are invasive. I mean, electroconvulsive therapy, ECT, we would consider that kind of invasive because you have to generate a generalized seizure, use anesthesia and whatnot. So on the other side of the divide is what we call non-invasive. And these are usually done mostly with the EEG, at least the one that we're going to be talking about, but there's others that can be non-invasive. But the ones that we're predominantly talking about in our research with autism and Alzheimer's disease and such are the following. Let me just pull up this other slide here. So these non-invasive, these are kind of some older non-invasive. These are more conventional based, but this transcranial, let me get this off the screen. Transcranial direct current stimulation is an example of non-invasive. Probably the non-invasive neuromodulatory intervention that's been studied the most is this one, transcranial direct current stimulation, and it's very, very safe. There's been about over 1,000 studies in tDCS, so it's very well studied. This is one of your typical protocols, you know, kind of over the kind of frontal parietal junction here, and you have a negative and kind of an exit here. And there's a very, very small current, and it's virtually imperceptible to the patient, usually around 1.5 milliamps. So to put that into perspective, ECT would use like 1,000 milliamps. This uses about 1.5. Usually there's 2, but this is a very common where direct current is being, kind of put into the brain, and you modulate. You kind of modulate the cortical area that you're interested in. And in the conventional one, they're pretty large, and you kind of had a lot of changes in the brain because the electrical field was quite large. So what we've moved to now is really being more directive with what's called high definition. So if you want to hit just one hub, there's ways to do that. We don't have to get into the details of that, but there's ways to take the patient's own structural brain imaging, find that particular area in their brain that you want to, activate, upregulate, or downregulate, and do that just in that area, or another particular area. So with high definition, you can be very, very focal on one area and get pretty specific changes in that area. So here's an example of some of that focality. So that is a non-invasive neuromodulatory intervention. The patient's relatively passive. They may be doing some particularly, they might be doing, so if we're working on executive function in our protocol, they're doing some executive-based task that we already have imaged them during that task. So we know that particular task is changing their executive function network because we image them while they're doing the task. So then when we're doing a particular technique, let's say if we're stimulating, over the parietal and the frontal, hubs, because we want to get these two hubs to talk to each other and be functionally connected, they're doing that task while they're doing the stimulation. So that's an example of high definition, transcranial direct current stimulation versus maybe the more conventional model, which sometimes is applicable to use, but you definitely get much more focality here. So that is one type of non-invasive, and there's a few others that are related to that. One is called alternating current stimulation, what we call tACS, which we're experimenting with in our autism protocol. So like a patient would come in, like you just saw on these other images, they would get one form of neuromodulation. So a lot of times we start off with an active form of neuromodulation, which is called neurofeedback. So there's no electricity being passed. We're just taking connectivity abnormalities that we think are relevant to the patient's, let's say in this case, executive disorder, feeding back those abnormalities in a form of treatment called neurofeedback, and looking at the changes in their cortex and then in their functioning. And then from there, neurofeedback is, because it's the only active form, it stays, it's a learning base. So like anything else, when you learn something, it's, your networks change, and you encode something and you ultimately hardwire it. And so that will stay, and then we'll see how much gain did we get. And typically in autism, you can get some improvement in executive function using neurofeedback, but typically it's not enough to, they might do a little bit better on functional testing of the executive network, but they're still not usually changing their functional status in the world. So we'll see how far we can get with that, and then they go into one of the passive non-invasive neuromodulation techniques, let's say like tDCS. So we might take, a couple really significant areas that we find that are disconnected in autism, and take two or more of those hubs and stimulate them at the same time, and do that. Typical protocol, they may do that 8 times in a row. Let's say within a couple of weeks, they may do that 8, 9, 10 times. And we do that for a number of reasons. One, we're constantly evaluating, did we change those hubs and those connectivities? So sometimes, even though we have a lot of nice tools to image and to tell us how to set up, a particular what we call montage, a treatment protocol, you still got to look and see, did it really hit? Did it really work? So sometimes that takes a session or two, and then you'll make the changes. The brain, as you see, will change, quite notably, but those changes will fade out, not from neurofeedback, because that's learning based, but the changes that you made on top of that, let's say an arm model, in this case with tDCS, will fade out in an hour or 2 or 3 or 4. But if you do it repetitiously over the course of a week or 2, you can get those changes in that network to hang, to resonate for a couple weeks. So in our model, they'll do 8 to 10 treatments. We call that a round, the first round of treatment. And then, we're re-imaging and retesting. And then they get a couple week break, and we're seeing if the gains hold. So they come back in a couple weeks. We re-image them again, and they start their second round. And they don't have to do, usually they don't have to do as much in the second round. They can do 4 or 5 treatments in the second round, and they might get 2 to 4 weeks of resonation. So the activity that you've changed in the cortex stays for, and hopefully the functioning level for, and then they'll come back for what we call their third round, maybe in 2, 3 weeks, sometimes even 4 weeks, re-image them again, and run maybe 3 treatments this time. And then we try to figure out, if they had some really nice gains, what is their maintenance schedule going to be? Do they need to come in every 45 days, every 30 days, every 15 days? So that's one model that we're looking at. But more commonly, what we do is, after their 3 rounds, what we typically do is what was called a washout. So we let the gains, whatever the gains were, whatever the changes were in the brain, whatever the functional changes we were able to garner from functional reevaluation, we let that kind of wash out over 4, 5, 6 weeks. And the reason why is because we want to compare this tDCS with another form or 2 forms of non-invasive neuromodulation. So we might then bring them back 6 weeks later and try, in this case, tACS, which is an alternating current, and we can pick the current. We might want to do it at 60 hertz or 90 hertz or 6 hertz between 2 areas in the cortex, maybe here and over here. That tends to be, so it'd be like a 4x1 design, for example, here, 4x1 design here, and then you're getting this parietal area and some of the the frontal area in the executive network, let's say Brodmann area 46 or something, to resonate at the same exact frequency, whether it's 6 or 60, and then we'll test that over the course of 3 rounds. We might test it at 60 hertz and wash them out again and then bring them back and test it at 6 hertz. So it's a lot of those kinds of approaches to ultimately find what is the best treatment protocol for the patient, which one did they respond most to, so that they can then stay on that for a maintenance period. So if they need to be treated, once every couple months, once a month, that we know what the best treatment is. So there's a lot of experimentation like that. So for this, to get back to your question now, for this patient here, this patient went through their first treatment, which was an active form of neuromodulation called neurofeedback. Made some gains, definitely made some changes in functioning. And then she went through 3 rounds of tDCS. And this is after the 3rd round of her tDCS. So this was whatever, maybe within a few days or a week of her last treatment of the 3rd round. So she would have gone through the first round, which would have been 8 to 10 treatments, a couple week break, 4 or 5 treatments, a few more weeks of break, and then 3 treatments. So that would be an example. Now what will happen with this particular patient, she's currently being retested functionally, see what the functional gains are. She'll go through her washout, and then we'll try a different form of neuromodulation and see if it's better than the results from this. And the treatments, like I said, are typically well tolerated, and not a lot of preparation that's needed. They basically come in, they take about 30-40 minutes, and pretty easy to administer. So because of that, we can get to do a lot of experimentation and try to find out for that particular patient what's the best treatment protocol, and that's what we go with on a maintenance. Because with these what we call passive neuromodulatory interventions, you have to keep introducing the treatment on some maintenance schedule in order to keep the gains. Okay. So that's an example of, so those are examples of, some of the more common non-invasive neuromodulatory interventions. So I go into, let's see, I think I might have on some of these slides here, let's see if I have them. All different changes here. No, I thought I was going to show you something back. So anyway, so those are the typical ones. tDCS, what's called tACS, transcranial alternate current stimulation, where has another dimension, and that's traditionally that's been used a lot in neuropsychiatric disorders, in particular, like overarousal disorders, but now being applied more to cognitive disorders. That's a very, very new area of research. There's another form called tRNS, which is random noise, where you can manipulate all different types in a very random fashion, frequencies from 60 to 500 hertz. We tend to look, we're looking at that in Alzheimer's disease in particular. So those 3, tDCS, tACS, tRNS, those are kind of the 3 main passive neuromodulatory interventions that we're studying here. And then the active one, again, is called neurofeedback. There's only one active neuromodulatory intervention. And what we mean by active is that the patient themselves is doing that based on learning. So those are the kind of the 4 main non-invasive neuromodulatory interventions that we're exploring in autism. Because we don't know for which given patient is going to work best. A lot of times they're taken through all of them with washout periods in between in order to identify if any of them are working, and if so, what's the best one. And when the seminar's coming up, once the data is collected, these studies started around November last year, so we'll be collecting data over the next couple years across these different clinical populations. So when that data is ready, we'll be presenting it. But that's what we're doing right now. And so patients who come into the clinic, some of this they get exposed to in the clinic. Some of these are not yet clinically approved for certain types of conditions. So those patients usually come into either a research study that we might be doing, or may become part of the we have to, a lot of times in supporting a grant application, we need to collect data. So a lot of times patients will participate in those grant application data collection projects, so they get exposed to these treatments. So yeah, so gives a little overview on what's going on. So again, I'll pause here because we're kind of nearing the end. If you have some questions, you'll want to either you can chat them in or unmute your mics, and we can talk a little bit about that. No? All right. Well, this will be recorded. Usually what we do is in a couple of days, we'll have kind of access to this introduction into some of these functional brain mapping methods and introduction into some of these neuromodulatory, non-invasive neuromodulatory intervention. It'll be up on the Neurocognitive Institute website. Christian will send you out that link to the attendees, and then you can access it as often as you like, because we did throw a lot of terms at you and some new concepts here. So like anything else, once you review it a few times, it will become a little bit clearer. But yeah, so if you have any patients who have autism and you want to further explore this, see if they would meet criteria for one of our research studies. Right now in autism, there's 3 protocols that we're looking at. One we talked a little bit about today is the executive dysfunction in autism. The other is language disorders. Some of the autistic patients have very significant language abnormalities, even beyond their language formative years, so even into adulthood. So there's another treatment protocol, same type of stuff we're talking about with functional testing and imaging, but it's over the language areas and trying to enhance language production. So that's another protocol that we've got going on that we're studying in autism. So there's the executive, there's the language, and then the third one is the social pragmatics. Those 3 conditions tend to be, more the prominent features across many patients with autistic spectrum-based disorders. So some of the patients come into the protocol if their language production or they don't have any language production, if that tends to be the one of the prominent deficits, they tend to come into that protocol. If the dysexecutive types of deficits that they have in executive system function tends to be the most prominent area of their autism, that usually they'll come into that protocol. Or those who social pragmatics, that interchange, that social kind of engagement, social knowledge, the ability to adjust their behavior based on the social information that they're registering, we call social pragmatics. If that tends to be the overwhelming prominent feature, they'll come into that protocol. So those are the 3 protocols that we're looking at right now in autism. All right. Well, thank you for attending. And like I said, if you have any other additional questions, you can get to us through the website or just give us a call. All right. So Christian, I'm going to log off, or Stella. I'm not sure who's on. So we'll get it up on the website, I guess, in a couple of days.
Yep. Okay, Dr. Tramontano.
All right.
Okay.
Thank you. Okay. Bye-bye.
Thank you.